So this session is for those who are already registered with us for our courses. We are taking this question and answer session for those who are already taking any course with us. This is an interactive session, question and answer session. We will not show you patients here. We will not take any class over here, but we will take your questions because we have taken classes with you via our server. So I got the first question, how to locate ovaries on TVS and how to see for a hydrocelebrities. This is the question from Dr. Anil. Now, the point is that first point is that TVS and TS, ovary scanning, I mean, when we are scanning the ovaries, TAS, we have discussed it in great detail in our courses, how to locate for an ovary on trans-abdominal scanning. We will not repeat everything over here because this is then question and answer session. What I will suggest you to go back to that class and go through how to locate an ovary on TAS. Now, the question is how to locate an ovary on TVS. This is the question from Dr. Anil. Now, first point, what you have to keep in your mind, whether you are scanning the ovary on TVS or TAS, is that the ovary. Now see, my ear is here. This is one ear and this is second ear. This has to be on this side and this has to be on the other side. But the ovary is not having a fixed location in pelvis. You have to keep this thing once for all in your mind. The ovary does not have a fixed location. Ovary can be here, can be here, can be there, even can be in Pouchow-Douglas. This is already discussed in your theoretical class, in the class of the female pelvis. Now the TVS. When I am talking of a TVS, I am having a long handle over here. But before that, what I will do, there is probably, yes, there is one class of TVS orientation. So please go to that TVS orientation of our gynae ultrasound course. So that is very detailed class. Now, when you are inserting the probe, now see, imagine that this is a TVS transducer. When you are inserting the probe, this is the tip of the transducer. This is the transducer itself. This is the handle. Transducer is over here. When you are inserting this, now see, this piezoelectric crystal, this is the piezoelectric crystal over here. Piezoelectric crystal is like this. Now see, in the probe, it is like this. Now, there is a elevation which has to be towards the ceiling. When your probe marker, that's probe marker is towards the ceiling, this piezoelectric crystal will be vertically like this. It means that now you are cutting anything what you are hitting from top to bottom, because this is a vertically placed piezoelectric crystal. When you are holding the probe with this indicator towards the ceiling. Now how to take the uterus, that is already discussed. Now when you are inserting in, then you have to rotate, you have to tilt this handle. Now see, this handle towards the opposite side to scan this ovary, this sided ovary. It means that if I am looking for a left ovary, now see, if I am looking for a left ovary, this handle has to go towards the opposite side. Then only this will hit the ovary. Now, where is the ovary? To start with, I told you, I don't know. Nobody can precisely tell you that the ovary is at 10 o'clock or at this angle, because it depends from patient to patient. Even it is different for two ovaries. Now you have to search, but the basic important point is that you have to rotate, not rotate, you have to tilt this handle toward the opposite side. Then only you can hit the ovary. That is the first point. Now the second point, if I am feeling any difficulty in visualizing the ovary on TVS, which I am not, because this is very these ovaries are easily picked by transabdominal ultrasound, but still I can see for a vessel, and that vessel is the iliac vessel, and in about a 90 if not more % of cases, the iliac vessel will lead me to the ovary, and it will look like the ovary is sitting onto the iliac vessel. Practicals are already shown to you in our courses. Now when I have inserted this probe and I got the ovary of this side, the any side, this probe marker, I mean this probe marker over here, and this piezoelectric crystal, maybe, now see, pay attention, maybe towards the ceiling or a bit tilted, because it depends on the ovary, how the ovary is lying. Please try to digest this. This is a very important point. For example, if any organ, any area of interest is vertically placed in the body, then this will be the long axis of that organ, and on rotation of 90°, this will be the transverse section. But question, are ovaries vertically placed? No. Are ovaries horizontally placed? No. Now I have to see how the ovary is in this particular patient. If, for example, ovary is like this, then on inserting the probe, I have to see for the length of the ovary, and that particular point, this marker over here will be this side. Now see, it will be northeast side. Then I got the length, and from here I have to rotate by 90°. That will be the transverse section of that organ. So the important point is that whenever I am scanning any organ, my probe is not like this always to take a transverse, and like this always to take the longitudinal section. Transverse and longitudinal section, when we are discussing, are with respect to body, not with respect to the organ. The transverse of the organ and the longitudinal of the organ will be decided by how the organ is. So this was a very brief answer. I'm very sorry, I'm having very lengthy answers because I want you to make understand. So this was a brief about the transvaginal scanning of ovaries. Now, the second question of Dr. Anil is hydrocelebrities. Now, where is the tube? Tube is in between. This is already discussed in your female ultrasound course. Gynecological ultrasound course, that is by the title of gynecological ultrasound. Okay, the question is posed where I have to answer. I will be answering in a brief, because this is already taken in one of the class, probably the second last class of the gynae ultrasound course. Now how to see for the hydrocelebrities? The tube itself is in between ovary and the uterus, and the long tube has to get fitted in a small area. Now whenever I am having a normal tube, there will be, I cannot see that on ultrasound. On ultrasound, I am not able to pick a normal tube. And if I am seeing a tube that is already dilated, it means that whenever I am seeing something, what is that something? I will come to that. Whenever I am seeing something in between the ovary and the uterus, that has to be first point is that, am I dealing with hydrocelebrities? Yes, this is the point. Now, what is that something? That something are the cystic areas, multiple cystic areas. Multiple cystic areas I will be seeing in between ovary and the uterus. Now, are they cystic lesions? They are actually not cystic lesions. They are transversely cutted. They are transversely cutted, these loops of the fallopian tube. Now I will follow one cystic lesion, and if it shows continuation with other, then it is not a cystic lesion. Actually, it is the dilated fallopian tube. That is first point. Second point is there will be incomplete septations. There will be incomplete septations in these cystic lesions, and that is the hydrocelebrities. So this was the first question, not the first one question. These were the two questions posed by Dr. Anil. Now, another question, what I am getting from Dr. Azhar, how to see for a pyramidal lobe of a thyroid. Now, first of all, the pyramidal lobe, we have discussed this in small parts. I will get here multiple questions, one from ovary, one from the thyroid, maybe one from the machine settings, because we are having multiple registered candidates who are registered for multiple courses over here. Now, coming to the question, the pyramidal lobe. The pyramidal lobe, now see, this is the thyroid. Where the pyramidal lobe is? First of all, the pyramidal lobe is a medial extension which is arising from the isthmus. This is normal finding. In about 40% of normal cases, we are having a pyramidal lobe. Now, the question is how to see for the pyramidal lobe. Now, this will not be this side, this will not be this side. This has to be somewhere in the center, because it will arise from the isthmus, and the isthmus is the connection between the two lobes. Now, if I see a mass-like structure which is arising, which is somewhere in the center, then I have to think 100 times before labeling this as a mass, because this is possible that I am dealing with a pyramidal lobe. Now, how to say that this is not a mass but a pyramidal lobe? Ultrasound is all about the implementation of theory. If you are not knowing the theory, please don't attempt to do ultrasound. Straightforward comment, straightforward suggestion. If you are not aware of theory, please don't attempt to do ultrasound. You are not photographers. People have turned from doctors to photographers when they are doing ultrasound. Please don't attempt this. Now, how can I say that whenever I see the mass, this can be mass also? Now, why not to compare the echogenicity of this so-called mass with the thyroid lobe? And if it is a pyramidal lobe, the echogenicity has to be same. Now, putting everything in one basket is that if a so-called mass which is arising in the center is having the equal echogenicity with my thyroid lobes, then I am dealing with a pyramidal lobe. Now, what you are thinking, I am telling this thing to Dr. Azhar. What you may be thinking that you can see an isthmus with a projection up. No, because they are not in one plane. They are not in one plane. One will be seen. What is what? Isthmus. Isthmus will be seen in one plane and the pyramidal lobe will be seen in another plane. That is why whatever you are expecting will not be there on screen. So I will try to draw this on whiteboard. Let me take the whiteboard. Does it come? Yes, no? No. Wait. So let me set the whiteboard. There. So what I was trying to say you that this is the thyroid lobe, this is another thyroid lobe, and this is the isthmus which is connecting it. Now, the point is that the pyramidal lobe is the medial extension. So this is the extension of the isthmus. This is pyramidal lobe. Here will be for the pyramidal lobe. Now the point is, on ultrasound, put this in your, keep this thing in your mind. Now, the ultrasound picture. How will be the ultrasound picture? Now, first of all, you have to be very clear with one thing, and that is that everything cannot be captured in one plane. Why? Because you are cutting one section. In one section, the other will maybe in another plane that maybe will not be seen. Now, on ultrasound, what I will be seeing? I will be seeing an isthmus. Now, see, I will be seeing an isthmus over here. Isthmus over here. Don't expect, now see, don't expect your pyramidal lobe to be like this. This is the point. Don't expect this to be like this on ultrasound because of the scan plane, which is not cutting through this due to the angle, due to the scan plane angle. Now, what you may see a mass-like structure over here, and you may see or you may not see the connection between the two. That is why you may get confused that I am dealing with a mass. This mass. So if you see an extension over here, then it is very clear. Then no need to discuss. But the point is, you may not see this extension because of the scanning plane, which is not exactly for the pyramidal lobe as well as the isthmus. Now, the point is, you are having a dual image. You are having a dual image. Let me resolve this. You are having a dual image. What for is that dual image? That dual image is not to save your paper, but it is for the comparison between the two areas or between the two organs. Now, this is the ultrasound monitor. This is the dual image. In this dual image, keep one thyroid lobe on one side and that so-called mass, what you are thinking, on the other side. Then compare if the echogenicity, ecotexture is equal to the thyroid lobe, then you are dealing with a medial extension, which is the pyramidal lobe. So this was the answer, a very brief answer of how to see for a pyramidal lobe of the thyroid. Now, one more question from Dr. Azhar again is that up to when I can see the yolk sac? It is very easy question. Wait. So the yolk sac, so usually, keep it here. So usually we are seeing the yolk sac up to 10 weeks, but the important point is that I should see a yolk sac. If it persists beyond 10 weeks, nothing to worry. But the point is, if it is absent and the gestational age is maybe 6 weeks or 7 weeks, that is worrisome. So up to when I can see, it doesn't bother me. But the point is, I should see a yolk sac. And if the yolk sac is missing, then there are high chances that the fetus is either already dead fetus or that fetus is at risk. We have discussed this thing in great detail in the early pregnancy course. Probably that is the 3rd or the 4th class. You have to go to that to see the importance of the yolk sac in detail. So the next question is, how to trace the uterine artery in a gravid uterus, at which point I have to take. We have taken more than 2 classes how to see for a uterine artery on real patients. We have shown you real patients, how to scan, and we have given you the techniques. You please go back to the class. And if you have not seen that class first attend the class, then this question should not be there. But anyhow, the question has been posed. I have to reply in brief. Where are the uterine arteries? If anybody can raise the hand so that I can discuss this one-to-one with any volunteer, preferably a gynecologist, having little or no knowledge of ultrasound. I'm repeating, preferably a gynecologist having little or no knowledge of ultrasound. And believe me, I will not torture, we will discuss. Okay, so please raise your hands, and we will send you the unmute invitation. So we will discuss one-to-one with one candidate. Gynes, please raise the hands. Why are you hesitant? Yeah, Dr. Uma Maheshwari has raised the hand. We have sent you the unmute invitation. Please accept the unmute invitation, and on accepting, you have to just say hello so that we can check our system that you are audible. Dr. Uma, say hello.
Hi sir, good evening sir.
Yeah, good evening. You are
Hello sir, good evening.
Good evening. You are audible. Are you a gynecologist?
Yes sir.
Yes or no?
Yes sir.
Okay. Dr.
Yes, sir.
Ashwita, wait. Dr. Ashwita, there
Hello.
are a lot of hands-ons. Dr. Shikha, Dr. Prachi, we have sent unmute invitation to all of you. You on accepting, say hello. Dr.
Hello.
Prachi? Yeah.
Yes,
What's
sir.
your name?
It's Prachi Chauhan.
Yeah. Dr. Prachi, you are a gynecologist, right?
Yeah.
Yes. Now tell me, where are these uterine arteries? Are these uterine arteries at the level of fundus, at the level of body, at the level of cervix, or somewhere at the level of isthmus? I've given you 4 options, and please control the background noise.
At the level of isthmus.
Very good. Now, some space are there. Please mute your microphones. Except Dr. Prachi. Okay. Done. Now, Dr. Shikha. Dr. Shikha, Dr. Uma Maheshwari. Say hello. Dr.
Yes,
Uma,
sir.
say hello.
Hello sir.
Yeah. Now,
Hello.
we know, yeah, we have got the reply
Hello,
that
sir.
yes, you are audible. I am addressing you only. Now, we know that the uterine arteries are not at the level of the fundus. We know that they are not at the level of the body. We know that they are not at the level of the cervix, but they are somewhere at the level of the isthmus. Now, Dr. Uma, how many uterine arteries are there? 2?
Yes sir.
2? Yes or no? Now, if there are 2 uterine arteries,
Yes, sir.
one has to be this side and another has to be this side. See to my fingers, this side. So these are the two uterine arteries over here, over here. Now I have to put a probe in the center. Then I have to angle it towards the right side or left side so that I will be hitting this uterine artery from the center. I will not straightway put the probe over here, but I will keep it in the center so that the beam is angled through the bladder to the iliac vessels. And when I got the iliac vessel, then I will see for a crossing vessel, and that is the uterine artery. Okay, so this is a very detailed, very detailed session how to see for and how to trace it. That is in your Doppler class. Yeah, Doppler. So color Doppler. If you are not registered for that and you want to go for the uterine artery scanning, you have to register for that course so that you can take the complete detail of the fetal Doppler. And if you are already registered, please go to the class and please open. There are more than 2 classes of uterine artery, 30 minutes, if not more each. So next question, if I can have. So next question, please. So the next question is from Dr. Kailash. Can we diagnose PID on ultrasound? Now PID, pelvic inflammatory disease. Now with this PID, we are having only one thing which is coming in our mind, that I will be seeing a fluid collection in pouch of Douglas. Not always. Not always I will be seeing the fluid in the pouch of Douglas if I am dealing with a pelvic inflammatory disease. Yes, it can be there, but not mandatory. It is not a criteria to make a diagnosis of PID with the fluid in the pouch of Douglas. Now, PID, pelvic inflammatory disease, this is a broad term used to describe the inflammation of uterus, adnexa. By adnexa, I mean the fallopian tubes, as well as the ovaries. Now, the question, if there is PID, why only one ovary will have the infection and the second will not have? Why only both ovaries will have inflammation and not the uterus? And why only uterus, not both ovaries? So the point is, if there is PID, then there are chances that everything, by everything I mean ovaries, adnexa, as well as the uterus will be involved. I told you, this is the mind game. This is the mind game. Ultrasound is mind game. You have to think more and you have to see and do less. You don't have to only do ultrasound. You have to first think, then you have to see. That is the point. Now, coming back to the answer. If there is an inflammation, then everything has to get inflamed. Now, if there is inflammation, there will be increase in size. This is the rule of inflammation. Now, the both ovaries will be increased in size. Not like PCODs. PCODs will have a typical necklace appearance, but they will be increased in size. Now, why not the uterus also increased in size? Yes, there are possibilities that the uterus is also increased in size. So if uterus is increased in size and there are bilateral increased ovaries also, and with the top up that I am having a POD fluid, that is PID, pelvic inflammatory disease. Now, if there is any gynecologist with me right now, they know how dangerous that PID is. A very simple diagnosis, pelvic inflammatory disease, can lead to ectopic pregnancy because there will be adhesion. We will not discuss the ectopics over here, but the point is this PID is very dangerous. This can be the only cause of her infertility. So don't miss the PIDs and don't overdiagnose a PID also, because maybe that the follicle has got ruptured yesterday and whatever fluid is in PID is due to the rupture of the follicle and unnecessary. You are over-diagnosing the case. So now see the importance of thinking more and doing less. If there is only and only POD fluid, that is not making a diagnosis of PID, because that can be due to other causes. And the one cause is that maybe the follicle has got ruptured. Now, with POD fluid, I should have an increased uterine size, and I should have an increased ovarian size also. Then only I can label this case as a PID. So this was a brief answer to your question. Oh, many questions are coming. Dr. Afroz is sending us the question for the fetal parameters appropriately, how to take it. So maybe that person is a fresher, and he or she wants to see how we can take the femur length. We are having a separate class for that. I will send you in your WhatsApp group that class, how to take the BPD, how to take the femur length. That is by the title of the fetal biometry. That is itself a class, and maybe that is not on our server. That is why this question has raised. So please remind me in the WhatsApp group. I will send you the fetal biometry class. Okay, next question. See, we are writing these questions over here. We are having an eye on this chat box. We are seeing for the hand raise options. So we are giving you the liberty whether to type in WhatsApp group, whether to type in comment box, whether to raise the hand. So now the question is how much should be the urinary bladder, fetal urinary bladder. Fetal urinary bladder, to say whether it is distended, over distended, or this is normal. So urinary bladder, fetal urinary bladder. Now, if it is more than 7 millimeters in first trimester, please note it, 7 millimeters, and you are in first trimester, it is distended. 30 and you are in second trimester, yes, it is increased. 60 and you are in third trimester, yes, it is for sure increased. But I am giving you something which is called as borderline, where the case can be normal or abnormal. Whatever 30, 60 and 57 I quoted, that is for sure a distended bladder. But 15 and more, 15 millimeters and more, if there is the diameter of the bladder, you have to think why. Now, if there is a bladder distension and that bladder is having more than 15 millimeters, 15 millimeters, what you have to see now? You have to see for the kidneys, and if kidneys are having hydronephrosis, we are talking of fetal kidneys. If fetal kidneys are having hydronephrosis, then you have to see for posterior urethral valve side. So the answer is that 15 and more you have to think, and 30 and more, it is always and always abnormal. So in the bracket of 15 and 30, that is borderline, and if the bladder is below 15, that is absolutely normal. Now, one more question, Dr. Sridhar, is giving us the question whether to rotate clockwise or anti-clockwise, because in our courses I am showing you live patients, and the rotation is like this. Now see, this is the transverse, this is the transverse, probe, this is the transverse. Now this is the indicator. This indicator has to be towards the right side. We know that. Now this thumb is the indicator of the transducer. Now I am giving you the liberty of whether to rotate it clockwisely or anti-clockwisely. No Mr. Google and no teacher in the world will give you this option. neither any book is written that there is an option to even anti-clockwise rotate it. But I am giving you the liberty whether to rotate it clockwise or anti-clockwise. But there is a condition applied. With my offer, there is a condition applied. Why? What is the condition? Condition is that the screen orientation will be get reversed, will be get inverted. Your superior will be replaced by inferior and your inferior will be replaced by superior if you will rotate it anti-clockwise. Now the question, what was the question? Question was, is there any advantage of anti-clockwise rotation? No. And oh no. There is no advantage, but if I will give you an example. If I am writing with my right hand, and I will be a big fool if I will everybody forced to write with the right hand only. I will be a fool if I will force everybody in the world to write with the right hand only, because maybe somebody is lefty. If I will force the lefty to write with the right hand, he will struggle whole of the life. Now what Mr. Google and our teachers have done, even the books, they are giving you only and only one thing: rotate it clockwise. And if anybody is a lefty on ultrasound, what I mean by lefty? Lefty does not mean that he will be writing with the left hand. No, lefty of ultrasound. This is the only term which I am using, and that is fact. If I am comfortable with anti-clockwise rotation, it means that my grip is not this way, but my grip is this way. Now, I am leaving up to you whether you are comfortable with clockwise or anti-clockwise rotation. That person can be lefty while writing anything, or he cannot be a lefty. But on ultrasound, he is more comfortable with anti-clockwise rotation. So I call him or her lefty of ultrasound, lefty on ultrasound. That's all. Now, if you know what you are doing, you are rotating it anti-clockwise, and your screen is a mirror image. The superior is on the other side, so it is a mirror image. We will not indulge in the screen orientation. Then this is the condition. Then I am giving you a liberty. Now you will check yourself whether to rotate this side or that side. That way, what you will do, you will check yourself whether you are righty or lefty on ultrasound. So there is no advantage, but you have to check whether you are comfortable this way or that way. That's all. Any more question? Let's see. One more thing, what I can say you. Dr. Zaitoon has posted in the WhatsApp group some days before a case, and she suspected it to be a CA, a gallbladder CA, and that was an antenatal case. You can go to the WhatsApp group and you can see that case. Now, whenever she put a color box onto that image, and that image is in your WhatsApp group, you can go to the WhatsApp group, you can see. And when I see that image, it doesn't look like a mass. Why she got confused with the mass is the color box. Whenever she put the color box with a high gain, color gain, with a high color gain, the artifact starts coming over there. And that doctor, I thought, that doctor, what she think? There is a mass, and that mass is taking color. Actually, that was an artifact which was filling in the color box. Now, when she rescanned the patient, and on rescanning, she kept the optimal gain, then next day, she was sending the case in the same group with a big thanks that this was not a CA or a mass, this was a sludge. So the important point is, basic important point is, you have to optimize the image. You have to set the this machine, and for that is our machine physics and machine settings course, complete course, which will take you about 10 days, if not 20 days to complete. Please, please, and please don't expect your machine to work for you. You have to work with machine. Machine will not work for you. Merely putting a color box and expecting the machine to show you the color, that will not do. That will not do. You have to put your brain and your eyes in the machine, then only it will work. So that was a case that turned to be a case of a GB sludge, and that GB sludge is very common in an antenatal case. And on the top there was a calculus also, and the calculus was topping up for the sludge. So anyhow, that was a sludge which she was about to label as a gallbladder CA. And for the gallbladder CAs, we are having a detailed course in our abdominal ultrasound. But the moral here is that optimize your machine, and don't expect your machine to do miracles for you, to work for you. No, your machine will follow whatever you will say, and you should know what to say. And for that, I will request everybody who is taking our course, please, please, and please don't take the physics and machine settings lightly. Please go to the physics and machine settings classes, and please revise those classes, because the physics is the backbone of the ultrasound. Point now to discuss with me, please raise your hands. So we will take on regular intervals, we will take these interactive sessions. This is not the end. This is the end of today's topic only, today's session rather, and we will be taking more interactive sessions. And what I will suggest you to please complete your classes in sequence and revise your classes. Dr. Aruna Saxena has raised the hand. I don't know whether it is by mistake. Okay, I will unmute her. Let us see if she has something to say. Us. Dr. Aruna, you have to accept the unmute invitation, and
hello, sir.
Accepting, you have to say hello so that we can check whether you are audible.
Hello, sir.
Yes,
good evening.
Hold on. I will say you when to say hello. Now.
Hello, sir.
Yeah, you are audible.
Good evening. Good evening, sir. Sir, I have completed this ultrasound physics course. I just wanted to understand few things. On the right of the screen, when you are doing grayscale, there's frequency, then there are certain more things written, like GN is gain or what? SA, map, DR. So I wanted to understand what are these things written on the right side, because we just know the depth and
wait. Yeah. Let me go to the one image so that we can make out. Where is the hard disk? Quickly. Where to put this now? Here. Yes or no? Yes or no? Wait. Yes, Dr. Aruna.
Yes, sir.
So I have got one image over here.
Yes,
So
sir.
I just wanted to confirm. I was confirmed. I want to show others what you are saying. You are saying about this, right?
Yes, sir. Yes, sir. Yes, sir.
So have you gone through the physics and machine settings class?
Yes,
I
sir.
mean the course.
Yes,
Okay.
sir.
Now over here, what I have to say, there are some important points over here. To start with, you have to see for those important points only. What is that? What is this
Frequency.
FRQ?
Frequency.
This is frequency.
Yeah.
So everything is over here.
Yeah.
You have to see for the frequency over here with what you are scanning now. So this is the frequency over here, and I am in B mode. B mode means I am in grayscale mode. Now this is GN. This is, forget about this also. Now this is mapping. There is a gray map in your machine, gray map. What gray map you are scanning will be displayed over here. Now what is that? Now if somebody is, now see, the eyes are different. Your eyes will like more gray, others will like more brown. So that is the mapping over there. In your machine, you have to see for the mapping. And this is the mapping, whatever is shown over here. And the most important is over here, depth. What is the depth?
Depth.
This is the D. Now see, D is written over here, not DEPTH. Now you have to make out that this is the depth. This is the depth. What is meant by the depth? Depth means that I am scanning right now with a depth of 9 centimeters. This is also over here. Now see, 0 is for skin. It means that this is over here. Now this is 8 and this is 9. Okay, so now whatever is beyond 9, maybe a 10, maybe a 12, is not seen over here. This is not a zoomed image. Please try to understand. This is not a zoomed image. This is a low depth. I will not say low depth. It is the depth with 9. If I will keep this depth as at 4, then here it will be 4 centimeters. It means that this 4 will now move where? Up or down?
It will down.
Down. Then will I see this gallbladder?
That will be, yeah. No.
Will I see that gallbladder?
No.
This is the point. Now, if somebody is thinking how much to keep the depth, this is the answer. I don't know. You know it better. Why? Because I don't know what you are scanning. And if you are scanning this CBD, now see, this is the CBD over here. If you are scanning this CBD, this is the appropriate depth. Because if I will decrease it more, then I will lose this CBD. Now, Dr. Aruna, question.
Yes, sir.
Why not to keep all times this depth high so that everything is captured in one image?
So you have to focus on the area of interest. If your area of interest is superficial, you can't keep the depth more.
Why? That is the point. Why I will not scan up to, now see, if this is the CBD over here and that is at somewhere at 7 and 8, why not to keep the depth at 70?
Because sir, your focal zone is somewhere here around 3.
No. I am not telling of focal zone. You are not getting my question. Why I put a depth of 7 or 8 over here only? Why not 70? If I will keep it 70, then whatever is beyond this point will be also seen.
Yes.
Why? That is not better.
No, but your area of interest will not be, the resolution will of area of interest
Very
will not be good.
Now the resolution will drop.
Yeah.
With increase in the depth, the resolution will drop. What will decide the resolution? What is deciding the resolution of any image?
The clarity of the image.
Frame rate.
Yes.
Frame rate is defining the resolution of any video, any picture. Now, this is the FR, this is the frame rate.
Frame rate, yeah.
Now, you have to make each and every attempt to increase this frame rate. And the first attempt is decrease the depth. By decreasing the depth, this frame rate will increase. then there are a lot of things, AO, then there is X beam. So what you have to see, important is the frequency. Most important, I will say, is this frame rate. Now see, frame rate is over here. Now question, with increase in this depth, Dr. Aruna, question.
Yes, sir. Yes, sir.
With increase in this depth, will this frame rate go beyond 24, 42, I mean more than 42, less than 42, or it will remain same?
Less than 42.
Should I repeat the question?
So if you increase the depth of the frame rate will go down.
Okay. Now see, I am repeating the question. If I will increase the depth, what will happen to the frame rate from 42? Will it drop or will it increase?
It will drop, sir.
It has to drop. Very good. It has to drop. So this is the point what you have to see over here. Okay. So this was all for now.
Yes.
In case you will be having more questions, whenever we will announce the next interactive session, we will update in your WhatsApp groups. Till then, bye-bye. Thank you. God bless all.
Thank you. Thank you.